The first physician speaker is from the University of Texas Southwestern, Dr. Hsia. And she's a pulmonologist who will share her perspective on sarcoidosis and overview. Not an easy topic. Her hand.
Thank you, Kelly, and good morning. And my name is Connie Hsia, and I'm a pulmonologist here at UT Southwestern, and I run a sarcoidosis clinic out of Parkland Hospital. So it's not straightforward to give an overview of sarcoidosis because it is so complex. When my patients ask, well, doc, what is sarcoidosis? That's usually the beginning of a 10-minute discussion. And so what I thought I would do here is kind of bring you right to the heart of all of this, to what is exactly a sarcoid lesion. This is a spleen that has been riddled with the lesions of sarcoidosis. You find lots of flesh-colored lumps. And these lumps, you can see them on gross specimen, and you can see them under imaging, such as CT scan. And then under microscope, you find that each of these lumps is made up of a bunch of smaller lumps. And each of these smaller lumps is what's called a granuloma. And each granuloma is an area of inflammation. And what you can see here, and use a little bit of imagination, I hope this resolution is good, is that it's an area full of cells that are very active. These are immune cells, lymphocytes, and other kinds. And they're busy. They're busy secreting stuff. They're busy communicating with each other. And they're busy causing inflammation. So this is an area of inflammation. You also get the sense that they're building a wall. These cells are working together, building some kind of a fortress. They're trying to wall off something, trying to isolate something, and that's a granuloma. And if you have enough of these granulomas, they start to replace, displace, compress, or otherwise mess with the normal geometry of the organ. So here's the normal lung, and here's a lung that's being riddled with these granulomas, and obviously they're compressing airways, they're compressing blood vessels, and the organ just cannot function normally. So these granulomas are the key to this disease, and these lesions can develop in any organ, most commonly in the lung, in the skin, and in the eye. And you say, well, what's in common with amongst these three organs? Well, they are three organs that interface with the environment. So if you get lesions in the lung, here's a normal lung, chest x-ray, and you can get infiltrates, which are strandy-like shadows, or you can get conglomerate masses in different parts of the lung. And if we do a CT scan, here's a normal CT scan with a nice-looking lung parenchyma. And in patients with sarcoidosis, you'll find these little nodules. Some are much bigger nodules or areas of consolidation. And there could be hundreds of these nodules throughout the lung. If these granulomas occur in the skin, you end up with nodules on the skin, can be anywhere on the face, on the eyelid. Sometimes they could look like psoriasis, as in this case here on the back of the neck. A common site would be on the legs, and if you have these granulomas, they can become confluent, deep, very painful red nodules, and sometimes that can be associated with fevers, and it's a very distinct syndrome. The granulomas like to occur in areas of scar, or these are areas of previous injury, and in tattoos, which are by definition areas of some injury. So you will see the nodules either within the tattoos and sometimes along the edges. They kind of bring out three-dimensional feelings to the tattoos. And when these lesions have been biopsied, you can find areas of granuloma and sometimes also containing the pigments of the tattoo. Any part of the eye can be involved, so one can end up with conjunctivitis if the granulomas are in the lens or in the fluid chamber of the eye. You can get floaters, you can get blurry vision, or if the back of the eye, the retina is involved, there can be these exudates that you can see over here. The nerves that control the eyes can be involved, so you might end up with an unequal size of the pupils. Or the eye muscles can become paralyzed, in which case double vision will develop. Or the tear ducts may become inflamed and you get a blockage of tears. So the manifestation is quite varied and it differs from patient to patient, which makes sarcoidosis such a difficult clinical disease to grab a hold of. Neurosarcoidosis is a distinct syndrome where granulomas are deposited in any part of the brain, and they show up as high-density spots on imaging. Or the granulomas can be deposited along the covering of the brain, the meninges, in which case you get meningitis, and on imaging you can see this confluent lighting up of the brain. Depending on where and what structures are involved, there could be paralysis, could be numbness or tingling sensations. If the lesions are deposited within the spinal cord, you can get paraplegia, and also there could be lesions in the spinal cord, in the bony part, which would then secondarily lead to inflammation or compression of the spinal cord. Cardiac sarcoidosis is another distinct syndrome, and you will hear more about that later today, where the cardiac muscle becomes inflamed and they are highlighted on MRI scans. So the presentation that you heard from Mr. Hobson is that instead of normal regular heart rhythm, one can get arrhythmia of different kinds, either irregular rhythm or degenerate rhythm, such as the one down here, which is incompatible with life. So sarcoidosis is really worldwide, and the incidence is increasing. But here in the US, in particular, there's a high incidence and mortality of the disease among African Americans, both in males as well as females. The incidence is more than twice of that in Caucasian population. The lifetime risk of developing sarcoidosis is also higher, and the mortality is higher. The reason for the difference is not entirely clear at this point, and also African Americans, when they do develop sarcoidosis, tend to develop it in more severe form. In other words, more organs are involved, more disability, requiring treatment for longer and having more complications. So here at UT Southwestern, we have sarcoidosis clinic and a clinical registry, and currently we have a little over 120 patients in the registry, and I just want to give you a little feel as to the kind of population. So the age it averages around 54, and that's consistent with sarcoidosis affecting a predominantly middle-aged population. The patients tend to be overweight because a lot of them have been treated with prednisone, which makes you gain weight. There's a predominance of female in our cohort, and a predominance of African American patients. And if we look at the organ involvement, the lung is almost always involved, and I think that is very instructive as to what is the cause of sarcoidosis. Among these patients, some have only lung involvement, others have lung plus multiple organs, as many as 6 total organs are involved, that means that these organs developed obvious, clinically significant abnormalities. Only 3% of the patients have no lung involvement. They might just have skin, or they might just have eye symptoms. So here's a graphic breakdown of the organ involvement, predominantly lung, followed by skin and the eye, and then you have various other organs, but basically anything can be involved by this granulomatous deposition. So in general, the evaluation of a patient who presents with something that perhaps we suspect sarcoidosis would always begin with medical history, a physical examination, and this takes a long time because every organ needs to be examined. We routinely refer patient for a complete eye examination by the ophthalmologist. To assess lung involvement, we would use X-ray or CT scan and a breathing test or lung function tests, which are very useful in providing objective measures of how well the our lungs are doing. Then we want to know how much inflammation is there. And that is done through a variety of blood and urine tests. And then a very important part is to obtain tissue for diagnosis from the most easily accessible organ that is involved. And this is important because we don't want to confuse sarcoidosis with infections. Certain infections can produce granulomas that look very much like sarcoidosis, and the major ones being tuberculosis and fungal infections. We also want to rule out malignancy, and here the big one is lymphoma, which can present very much like sarcoidosis. So that's why a biopsy would be necessary in order to rule out that possibility. So once we have a diagnosis of sarcoidosis, preferably based on a biopsy specimen, then the evaluation comes down to understanding what is the extent of the disease, how many organs are involved, what is the severity of the disease, how bad are the symptoms, how bad is the disability that it's causing, and the activity of the disease, that is, what is the burden of the total body inflammation. And based on these considerations, we would then discuss with the patient about the need to treat. Realize that in many patients, sarcoidosis can resolve spontaneously over a period of 1 or maybe 2 years, and that treatment is not curative because we don't precisely know the cause, so we cannot precisely target the treatment for curative intent. And the treatment has many side effects, and it has to be taken over several months. So if there are no symptoms, or the symptoms are just mild nuisance, then the patient may not need treatment at all. If the patient has moderate to severe symptoms, or if there are major organ involved, for example, deterioration in lung function, or cardiac involvement, or neurosarcoidosis, then most definitely they would need treatment. So I will talk about treatment only in general terms because you'll hear about that some more later. For the mildest cases, we would use non-steroidal anti-inflammatory drugs. The next line would be corticosteroids, prednisone, or then immunosuppressive drugs to replace or reduce the dose of prednisone that's needed in order to reduce side effects. Sometimes antibiotics, antifungal drugs are added, and then depending on which organs are involved, there may be organ-specific therapy. Complications of sarcoidosis, obviously organ failure, sometimes more than one organ are at risk for failing. And drug side effects, that's a big one when you have to take these drugs for months at a time. And then opportunistic infections, that is infections by organisms that are normally around us but normally do not cause any problem in a healthy subject. But when patients are immunosuppressed, and then they're more likely to get these kinds of infections. And then there's a risk of a secondary malignancy. Either it's malignancy that's associated with the sarcoidosis reaction or as a result of the immunosuppressing drugs. Okay, so now the conventional view then, overview that we would give, or textbooks would give, is that this is a granulomatous inflammation involving many organs. The cause is unknown and probably different in different patients, and therefore the cure is unknown. The treatment is empiric, with the goal of suppressing the inflammation to relieve the symptoms, reduce disability, and to minimize side effects. So you look at this picture and you go like, well, okay, that's not very encouraging, right? And I would propose that at least one of these, the cause unknown part, is not exactly true. We do have some idea as to what causes sarcoidosis. Because there are various other syndromes that produce granulomatous inflammation that look almost indistinguishable from sarcoidosis. The only difference is that we know exactly what caused them, whereas in sarcoidosis we don't have a handle on what's causing that syndrome in a given patient. So one example is beryllium. So exposure to beryllium produces a syndrome that is identical to sarcoidosis. And beryllium is found everywhere in the industrial endeavors, especially in aerospace-related industry. It's used in the manufacture of satellites, aircraft, missiles, ceramics, various metal works, as well as in mining. And here's the granuloma, and here's what the chest X-ray looked like. So if you didn't know the patient had been exposed to beryllium, if you didn't have that history, you would have called it sarcoidosis. Same thing with crack cocaine. And especially inhaled or actually intravenously introduced cocaine into the system can produce granulomas, and on biopsy you might find the crack crystals within the biopsy specimen. And again, the X-ray and the clinical picture can look very similar to sarcoidosis. The exposure to talc powder is another known cause of granulomatous inflammation. Again, the similar type of clinical presentation and pictures. Let me go down here. And on biopsy, under special lighting, you could find these talc powder deposits within the granulomas. This is called the 9/11 sarcoidosis, exposure to mixed dust. So in the New York City Fire Department rescue workers, those who had participated in the World Trade Center cleanup, they have a higher incidence of developing sarcoidosis-like syndrome. And in the years after the 9/11 disaster, there was a spike in the incidence of sarcoid-like disease among these workers, which then dropped down to a lower level, but you notice it's still not at baseline, it's still somewhat elevated. So they are at risk because of their exposure to just dust of all kinds. So that, I think that's also sort of instructive in terms of our understanding of sarcoidosis. More recently, it's being reported that household black mold, and this is fungus, can be associated with sarcoidosis. And so if your household has a vent that's got these deposits, or your walls that look like this, there's an association of that with the occurrence of sarcoidosis. It depends, of course, on individual susceptibility. Some people are more susceptible to that, or their immune systems are more susceptible to being activated by these antigenic exposure. And of course, now we come to the tattoo pigments. I was astounded by the number of different metals that go into these beautiful colored pigments. Okay, we have the alphabetical list here from aluminum, barium, cadmium, chromium, cobalt, all the way down to titanium, zinc, and mercury is in there as well. All right, and it's not just metals, but metal oxides, which are ferrocyanide, ferric cyanide, organic chemicals such as azo compounds and naphtha compounds, and carbon, which is black soot, and various other elements that include arsenic and so on. Now, to get the exact hue, the beautiful hues, these pigments are typically blended, and lead or titanium are added as lightening agents. Okay, so just to summarize the postulated triggers of sarcoidosis, antigens of various infectious organisms such as tuberculosis or fungi, malignancy, breast cancer, lung, GI, and so on, can be associated, can trigger the immune system to cause a sarcoidal-like reaction. That's why we need to have a search for possible malignancy. And then exposure to metals, to dust. Pine pollen is always thrown in there, and it's not clear to me how good that evidence is, but then of course substance use, either intentional or unintentional exposure to foreign substances that are introduced into the body. And then we have pollution. So the incidence of sarcoidosis worldwide is increasing, particularly in urban centers. And according to the American Lung Association, 52% of Americans are exposed to a polluted air on a regular basis. So therefore, there is the possibility that there's a link between these two events, but not too many studies have addressed this particular issue. So to end my overview here, I want to bring you back to the fundamental lesion of sarcoidosis, which is this granuloma. And again, you know, if we just look at it, right, we're seeing these cells trying to build a wall. They're trying to wall off something. They're trying to isolate something. They're trying to protect the rest of the body from some foreign substance. And I subscribe that as patients, or at least I always tell my patients that the first thing they need to do is to start reviewing their lifestyle, their environment, their neighborhood, their workplace, and trying to see if they can identify any triggering agents that might have contributed to their disease, and that if by minimizing such exposures, it would have beneficial impact on the severity of the disease, on perhaps reducing the progression of the disease, and also possibly prevent the development of disease. The one last point is that, as you know, there is a tendency, or there have been familial clustering of sarcoidosis. That is, several people in the same household might develop sarcoidosis. And although many years and many studies have gone into looking for the genetic cause of sarcoidosis, there has been no smoking gun genetic cause found, which would suggest that these clustering among families might be related to shared exposure to common triggering factors. And so that would be another reason for thinking about that particular angle. And with that, I will just stop and thank you.